Hi. A warm greetings from Dr. Nallaperumal, the Senior Consultant at MGM Healthcare Chennai. Today, we are just going to see about pregnancy diabetes. Even though the topic is gestational diabetes, I will just tell you briefly about the problems faced by mothers when they get diagnosed very early in pregnancy. Sometimes it could be pre-gestational diabetes as well. So I'm going to talk to you about the importance of screening for pregnancy diabetes and the way it should be managed throughout pregnancy and post-delivery issues as well as the future precautions. When it comes to pregnancy diabetes, well-controlled diabetes in pregnancy is very, very important for the future of the baby also. It plays a vital role even in preventing non-communicable diseases like diabetes, hypertension, dyslipidemia in your children. So if you take care of your pregnancy nicely, then obviously you are protecting your child for the future. So let me share the presentation and then take this forward. So when you do the pregnancy test and get a confirmation, joy is all around. The entire family is elated. And when you choose to go to a gynecologist, obviously the gynecologist will be doing the basic blood tests. Suppose if the test results reveal that you've got a borderline problem with sugars or undiagnosed diabetes around that time, then a lot of people get devastated because this is not a period to think about diabetes, and many people won't even know what is diabetes, and many people feel depressed or even do protests like to the doctor, why I get such problems, what wrong I have done. Then the anxiety sets in. Then finally they come to grips with the current problem and then start negotiating with the doctor, like what I should do. Then the fear, like whether this diagnosis is going to have implications for the baby and whether this whole pregnancy is going to take a turn for the worse. All that fear comes into your mind. But well-controlled diabetes, well-managed diabetes, you need not worry about anything. So we will just go through this presentation to understand the intricacies of pregnancy diabetes management. So when it comes to pregnancy, a woman's free stress test during the whole 10 months. Actually, when somebody is having, say, cardiac problem without much chest pain or anything, the regular ECG may not reveal any problem. But when they do a stress ECG, they find out that the heart is in trouble. So whenever a person is undergoing stress, the background problems get revealed. Similarly, during pregnancy, because of the hormonal changes which happen during pregnancy, till delivery, your metabolism is taking it in the right way, and your system is coping up with the demands of pregnancy, then obviously your health is very good. Suppose if at some point you develop pregnancy diabetes or pregnancy-induced hypertension, that it has got some implication for the baby as well as for the mother in the future. All of us know that we inherit DNAs. We inherit DNAs from both our parents, genes, and our parents inherited them from their parents. That means a child inherits genes from at least 6 people, from the mom and dad and the grandparents of both sides. Your child is a mix and match of such DNAs of few generations. So this picture reveals it all. Like the father is wearing a horizontal striped shirt, the mom is wearing a vertical striped shirt, and the baby is wearing a check shirt. It's like both the dad and mom has contributed genes to the child. Does this mean that if a family has got diabetes or hypertension, the next generation should have it? Not really, because your DNA is not the only destiny for your children. The way we live, the way we handle the issue is also important. It is called epigenetics. So the environment with which we are living, that also plays a role in altering our DNAs. That means a mom who is taking care of the fetus nicely during pregnancy is going to protect the fetus, the child, for the future. So that's why Abraham Lincoln quoted, "All that I am or hope to be, I owe to my angel mother." So this statement is really true. And before going into the complexities of pregnancy diabetes, so I'll just tell you about the physiology and little bit of anatomy, because the fetus derives nutrition from the mother through the placenta. This is the placenta, the brown colored one, and it is the connection between the mother and the baby. And the placenta is connected to the umbilical cord, a wire-like structure which connects the baby to the mother. So the placenta supplies all the nutrition from the maternal side, mother side, to the baby through the umbilical cord. Placenta, apart from doing the nutrition transfer, it's also secreting two important hormones called human placental lactogen and placental growth hormone. So these two hormones slowly go on a surge as the pregnancy advances, and these two hormones produces insulin resistance. Because of the placenta related hormones, your insulin's action slowly comes down. If your pancreas is able to cope up with the increased demands of pregnancy by secreting more and more insulin, then your sugars behave normally till delivery. If at some point your pancreas is not able to cope up, then slowly the insulin resistance takes over and the blood glucose level starts going up. So this is gestational diabetes. During pregnancy, because of the placental hormones, your insulin's action is getting impaired. Whereas a mother who is having undiagnosed diabetes or pre-existing diabetes, they have got insulin deficiency even before becoming pregnant. So that becomes a big problem, because as soon as she becomes pregnant, because of the placental hormones, the insulin resistance keeps rising from the start. So that is why screening for diabetes is very important before planning pregnancy. So diabetes in pregnancy, we can classify into four major types. One is pre-existing diabetes, what I've quoted already. It could be a type 2 diabetes or type 1. Type 1 diabetes, which occurs in children and young adults. They require insulin continuously. So they are insulin dependent diabetes. Whereas type 2, majority of them will be on oral medications. There is another category, pre-existing pre-diabetes. That is, they do not qualify as diabetic patients, but their glucose levels are not normal either. They fall somewhere in between. It is called pre-diabetes, at risk for diabetes. So it could be impaired fasting glycemia, where only the fasting glucose is slightly raised, or impaired glucose tolerance, where only the after food glucose level is slightly raised. And then the other group is overt diabetes diagnosed in pregnancy. These people never had any symptom. They were absolutely normal. They became pregnant and went to the gynecologist. The initial tests ordered by the gynecologist reveal that the woman has got uncontrolled diabetes. This is a dangerous problem, where the baby got exposed, the fetus got exposed to high levels of glucose during the critical period of organogenesis. The fourth type is gestational diabetes, where the mother is a normal person. Just because of the stress of pregnancy, in the midst of pregnancy, she develops gestational diabetes. So the first three are very important. We need to diagnose these three types before conception itself. If you have a plan to become pregnancy if you have risk factors, which I am going to tell you in a few minutes from now. If you have such risk factors, it is better to get yourself screened for any undiagnosed diabetes so that it can be properly controlled. And a well-controlled diabetes becoming pregnant is as good as a normal person becoming pregnant. So we need to absolutely be aware of this problem. So who are all at risk to develop diabetes? If your age is more than 25 years, now it is very common that people are concentrating on their profession, they are career oriented. So marriageable age is getting delayed. And then even after marriage, child bearing is little delayed. So all that because of various reasons. So most mothers come to the hospitals at say 30 or 35, around that age group. So age beyond 25 years is one of the risk factors. Ethnicity, being an Indian itself is a risk because compared to Caucasians, whites, we have 5 times more risk of developing regular diabetes. So similarly in pregnancy also, we see more pregnant diabetic patients than in the Western world. And if you have a strong family history of diabetes, suppose if either of your parents are diabetic or your siblings, your brother, sister, somebody is having diabetes, then that's a very important risk factor. And if you are obese, overweight, for your height, if your weight is on the higher side, then you have a higher risk. If you have polycystic ovaries, PCOD, then you have a higher risk. Then if you have previous gestational diabetes, in the previous pregnancies they diagnosed gestational diabetes for you, then it's a risk. Previous history of big baby. Sometimes the screening may not have been done properly, the previous pregnancies, but the baby was born big, say 4-kilogram baby. In such cases, probably it is a case of undiagnosed gestational diabetes. So then this pregnancy also carries some risk. Then previous fetal loss, any history of abortions or intrauterine death, fetal demise, all that is a risk factor for gestational diabetes. And why we are more worried? Because Asian Indians, the GDM is more prevalent and it is occurring more and more in younger people. See, this data on the left, you can see that in the cartoon, the age groups on the x-axis and the prevalence of gestational diabetes on the y-axis. You can see younger age groups, they get very less incidence, whereas as the age increases, the risk for gestational diabetes also increases. But when you compare this white population, Asians, they have a higher risk for developing gestational diabetes, even in the 25s, 30s, early young age, as well as the risk is far higher than the whites. So we have more risk as an ethnic group. And how we diagnose pregnancy diabetes? As I have told you before, we've got various types. Pre-gestational diabetes is diabetes which is present prior to becoming pregnant. So if the fasting plasma glucose is more than 126 or 2-hour value is more than 200 or HbA1c is more than 6.5%, HbA1c is the last 3 months average, then it qualifies as pre-gestational diabetes. And gestational diabetes, we normally do oral glucose tolerance test in the fasting state. If any of the values cross these cutoff values, fasting should be less than 92, 1-hour value should be less than 180, or 2-hour value should be less than 153. Then we can diagnose gestational diabetes. Whereas the Indian DIPSI criteria says any time of the day you can just walk in, have the 75 grams glucose, and then 2 hours later you give a sample. If it is less than 140, it's normal. Anything above 140, it is gestational diabetes. So suppose if you have plans to become pregnant, what you should do? First, you should go to a good center, discuss with the gynecologist about the plan to become pregnant. They will order certain tests and they will look into certain risk factors. First, you have to plan a safe contraception in planning phase if you have diabetes, because we need to control diabetes before achieving pregnancy. And we have to achieve near normal HbA1c, which is around 6.5% if possible, or at least less than 7%. Then all of you should be on folic acid supplementation, because folic acid is one vitamin which is required for the baby's brain growth during the initial stages. And if you have hypertension, if you have high blood pressure and you are already on medications, then your medication should be reviewed, because there are certain medications like ACE inhibitors or ARBs which can cause anomalies in the baby. So we have to change the antihypertensive drugs to a safer option. And then if you have thyroid dysfunction, then it should be corrected, because that is also important for the fetal growth. And any other medical treatment. So suppose if you are having depression, you are having anxiety, and you are on antidepressants prescribed by a psychiatrist, then obviously we have to review the safety of such medications. And then if you have pre-existing diabetes, we have to screen and treat diabetic complications like retinopathy and nephropathy. So you have to undergo a dilated eye examination with a good ophthalmologist, as well as you have to check your urine microalbumin to rule out early nephropathy. So all this need to be done before becoming pregnant. And what we aim for, pregnancy targets are different. So before conception, your fasting plasma glucose should be less than 100, and 2 hour post meal glucose should be less than 140 milligrams, and HbA1c should be less than 6.5%. Whereas if you are pregnant already, then we need to tightly control the sugars, because that's what the baby requires. So everything revolves around the baby during pregnancy. So the baby's tolerance sets the standard for the pregnancy targets. So the fasting plasma glucose should be less than 95. And 1 hour, if you're checking your sugars with a glucometer at 1 hour post meal, then it should be less than 140. If you're checking at 2 hours, then it should be less than 120 milligrams. That's what we aim for. And whenever you are checking the postprandial blood glucose, you have to start from this, time it from the start of the meal. See, in pregnancy, pregnant mothers will have some nausea. They tend to eat rather slowly. So even a breakfast, to consume a breakfast, to finish the food, they may take 25-30 minutes. But your digestion starts when you start eating. So you time your test from the start of your first bite, and then check at 1 hour or 2 hours. And why pre-pregnancy planning is critically important? Because by the time a woman knows that she's pregnant, obviously she misses the periods, and a week or two later she realizes this may be pregnancy, in natural conception especially. So by the time she reaches the gynecologist's clinic, it is already 6 to 8 weeks of pregnancy. So if you look at the development of vital organs, the central nervous system starts developing from 2.5 weeks to 7 weeks. And the heart develops between, say, 3 to 6 weeks. So by the end of 6 weeks, you can see the heartbeat in the ultrasound. So that means the heart is formed and it's already beating for the baby. So by the time a woman reaches the doctor, if she has got undiagnosed diabetes, the exposure of the fetus has happened already. So that is why pre-pregnancy planning is critically important for all people who have got diabetes already. And what about HbA1c? HbA1c is the last 3 to 4 months average. And the normal value, already I've told you that it should be less than 6.5. If you look at the anomaly rate, there is a in the x-axis you see the HbA1c levels, and in the y-axis you see the anomaly rate per 1,000 live births. So even the normal person, even in the non-diabetic, apparently normoglycemic mother, about 20 to 30 babies can have minor anomalies out of 1,000 live births. So we can't just say any anomaly is due to diabetes, because there is a small risk for all the babies, about 20 out of, say, 1,000 babies. But if the problem, the diabetes is uncontrolled, and the woman without controlling her diabetes becomes pregnant, or without knowing that she has got uncontrolled diabetes, she has become pregnant, then you look at the anomaly rate here. So even at HbA1c 10 to 13, about 100 to 180 or 200 babies out of 1,000. That means 10 to 20% of the babies can have congenital anomalies. So we always tend to look at the brighter side. Even if the HbA1c is on the higher side, even though the exposure has happened, still 80 to 90% of the babies will be normal at birth. So if the couple is willing to take that risk, because nobody can assure, only when the baby is born, you will fully know whether the baby is completely normal or not. But since the anomaly rate is small and the chance that the baby is normal is very high, and with the technology is advancing, we have got good ultrasound technology now. 20 weeks we can do a anomaly screening and then take a decision. So now we don't advise any termination of pregnancy. We explain the risk to the couple and continue the pregnancy, intensively control diabetes with insulin, and then majority of the babies will be normal in such instances. So what happens if the mother's blood glucose remains uncontrolled? This is the placenta, where you see the maternal blood glucose cross the placenta. Suppose if the blood glucose level is 170 for the mother. Glucose being the smallest nutrient, the placenta cannot filter it. So obviously it just crosses through the placenta and reaches the baby. Whereas if the doctor chooses to give insulin to control sugars, injected insulin never crosses the placenta, because insulin is a big protein molecule. It's got a very big molecular structure. So the placenta is a nice filter. It will never allow the injected insulin to pass through the placenta to get to the fetal circulation. So no worries about injected insulin reaching the baby. Whereas the blood glucose reaches the baby, and what it does, it stimulates the baby's pancreas, because the baby's pancreas is already formed by 9 to 12 weeks of pregnancy. The fetal pancreas gets stimulated continuously because of uncontrolled maternal blood glucose. That leads to high baby's insulin level. So because the pancreas works, when the glucose level from the mother is uncontrolled, naturally the baby produces more insulin to control its own blood glucose levels. So the baby enters into a syndrome called insulin resistance syndrome, where the baby is becoming huge because of the high insulin levels, as well as the glucose getting deposited as fat in its body. So this leads to macrosomic baby, big baby, as well as other complications. So these are the complications if we don't control the blood glucose in the mother. Normally, we don't discuss all these complications to the pregnant mother, because it is our job to control it. And if they follow whatever we advise and cooperate in terms of monitoring, as well as taking insulin shots if necessary, then the complication rate is very, very minimal. So pregnancy is a happy occasion. So generally, we don't discuss all the complications so that the mother will go into a fearful mode. It's not required. So this is one complication which happens quite frequently, macrosomia, big baby, that can lead to a problem during vaginal birth. So in this picture, the bigger baby is the baby on the left side is a big baby, on the right side is a normal baby. And this question always comes up during discussions. Big baby, is it always due to diabetes? If you have pre-gestational diabetes, and if you have gestational diabetes uncontrolled, then it could lead to a big baby. But at the same time, there are other factors which play a role. If you have pre-gestational obesity, if you are obese or overweight before pregnancy itself, or if you have gained excess weight during pregnancy, these two factors can play a role despite your good control of diabetes to make the baby big. So bigger the mom, bigger will be the baby. So if you are overweight or obese prior to becoming pregnant, you have to try to lose weight before pregnancy. That improves your chance of becoming pregnant also, because obesity is one of the factors which causes fertility issues. By losing weight, you are improving your chances of becoming pregnant if you are planning to become pregnant. So try to lose weight before pregnancy. And losing weight before pregnancy also reduces your risk for getting gestational diabetes, because you are reducing the pre-existing insulin resistance by losing weight. And the risk of childhood obesity in your infant is also reduced. So obviously you are giving the benefit to the child also. And if you are overweight or obese, limit weight gain during pregnancy. This is very important. Already you are overweight and you have become pregnant. So now you need not gain like all the pregnant mothers do, because already you have a lot of energy resource in your body by the way of excess fat. So your weight gain should be minimized during pregnancy. And if you are obese with gestational diabetes, the former contributes more to childhood obesity. That means you have obesity before pregnancy and you have developed gestational diabetes. Which one contributes more to a big baby? It is obviously your obesity. And if you have pre-gestational diabetes and obesity, obviously strict sugar control is very, very important. It is mandatory. And the other end, smaller baby. Sometimes they land up with intrauterine growth retardation. So again, diabetes is one of the reasons for it, especially if you have uncontrolled diabetes in the early stages of pregnancy. The placenta formation could get affected. That can lead to smaller baby. Or the commonest problem is high blood pressure. If you have blood pressure prior to becoming pregnant, then that is an important reason. Or PAH, pregnancy-induced hypertension, especially early in the stages of pregnancy, that can lead to a smaller baby because the placenta constricts. And if you have severe anemia, or you are already underweight, or your weight gain during pregnancy was not to the optimum level, or you have become pregnant without much interval between the pregnancies, or if it is a twin pregnancy, then this can lead to smaller babies. There are other factors like chromosomal abnormalities, birth defects, or rubella and placental abnormalities. And why we want the baby to weigh within the normal range at birth. Why it is so important to have a normal weight baby? Because if the baby is very low, like low birth weight babies, they have a problem of developing future risk for all the non-communicable diseases, including diabetes. If the baby is overweight, again, they have a higher risk to continue as obese or overweight adolescent, adult, and then develop diabetes in the later stage. Obviously, both ends of the spectrum, very small baby and very big baby, both the babies are at a higher risk to develop diabetes when they become adults. So by regulating the baby's weight during pregnancy, we are contributing towards reducing the risk for the child to develop diabetes in the later stages of life. So nice control of diabetes in pregnancy ensures a healthy passport to your baby. So it is not about the pregnancy outcome only. It is about the future of your child. So maternal diabetes influences all aspects of pregnancy, starting from conception through birth, and then subsequent health of the child, as well as when the child becomes an adult. So the simple advice, if you become pregnant, do what your mom did. Try to do all the household work. Our elders were always right. So try to be active during pregnancy. You have to check with your, obviously, obstetrician or gynecologist whether regular kind of exercises are allowed, because there are some situations in pregnancy where the doctors don't advise much exercise. Other than that, provided your primary consultant, the gynecologist, agrees, then you have to do the exercises recommended by them, so that you reduce your risk to get gestational diabetes, as well as the treatment. If you have gestational diabetes, then your insulin requirement, everything will come down with good activity. So there were a lot of traditional exercises which our elders were doing. Now, obviously, with mechanization and urbanization, all these are gone now. But anyway, the new exercise for most of us is texting. This is just on a funnier side, but obviously you have to be active. That's the message. The other challenge is, like, everyone will have their own doubts. What to eat? And there is always the pampering. A lot of people will advise, like, eat for two. This does not apply when you are in the early stages of pregnancy. In the early stages of pregnancy, the fetus is just forming the organs. Slowly it is developing. So at that point of time, you just take nutritious food. You need not eat for two. Once you reach 20, 24 weeks, then the baby starts growing faster. Then depending on your ultrasound picture, as well as the gynecologist advice, then you will be stepping up the intake of your calories. And there will be a lot of free unsolicited advice from near and dear. The other extreme is going on a diet to avoid insulin. If somebody gets diagnosed with gestational diabetes, they want to avoid insulin, so they go on to a very strict diet, and naturally they deny proper nutrition for the baby. That's the other extreme. So the baby should never be denied about its requirement. And your meal plan should be highly individualized. You have to check with the dietitian about your current intake of food, and then discuss with them about the ways to change your food habits favorably, so that the baby grows nicely. At the same time, your sugars are kept under control. And when the dietitian advises you, she'll be taking into a lot of things into account, like your personal preferences, your current body weight, your activity level, your blood glucose levels, time and type of insulin injections. If you are already on insulin, everything will determine your meal plan. And your calorie intake must be compatible with the state of pregnancy. We divide the pregnancy into 3 trimesters: first trimester, second and third trimester. Obviously, during the third trimester, you'll be encouraged to eat more. And you should ensure proper weight gain. That's very important. So these are the glycemic targets for pregnancy. We aim for fasting glucose of less than 95, and 1 hour value of less than 120, and 2 hour value of less than 140. And how do we manage pregnancy diabetes? By asking pregnant mothers to do home blood glucose monitoring. That involves using a glucometer and pricking your fingertips. So you have to do it in a structured way. That means you'll be doing multiple number of times in a single day, not every day, at least twice every week, so that we'll know the trend. Suppose if you have early pregnancy diabetes, then since the baby is still forming the organs, we may be little more aggressive. The monitoring may be little more frequent. Once we become comfortable, then the frequency can be reduced. So this is one of the charts. Like you can see that the pregnant mother has recorded the dates, the fasting level, the current insulin dose, and then post breakfast, post lunch, and post dinner. So fasting as well as 3 post meal need to be checked at regular intervals, so that the doctor can adjust the insulin dose if you are on insulin. But obviously this involves multiple pricks. The current technology is continuous glucose monitoring, where you have a small sensor which is attached to the arm, and then you will be just using a reader. You just take this reader close to that sensor, and it will display the result immediately. This technology is available in Chennai now, so it can be used. You have to get the reader. It's a one-time investment, whereas the sensor can be used for 14 days. So once in 14 days, you have to change the sensor. And with the sensor on, you can just do about your normal activity. You can even swim. So it is attached securely to your arm without causing any pain. And this is a sensor. This is Nupur Lalwani, a type 1 patient who is wearing a CGM sensor to control her diabetes. So when you have CGM, like continuous glucose monitoring on, then we have time in range goals. You can see on the left side, this is a time in range for the regular pre-existing diabetic patient, type 1 patient in pregnancy. In type 1 patients who are on insulin throughout their life, who are pregnant, they have a lot of fluctuating blood glucose levels. So we are more worried about hypoglycemia, low sugar. So for them, the target is little relaxed. So the time in range should be more than 70%. That means 70% of the time they should spend their time in range, the target range. Whereas in gestational diabetes and type 2 diabetes, the hypoglycemia risk is very less. So we expect them to spend almost 90% of their time in range. So this is the ambulatory glucose profile. When you have that CGM there in your arm, we can download data from the CGM like this and analyze or interpret the readings. You can see the time in range is 74%. If it is type 1 diabetes, it is fine. If it is type 2 or gestational diabetes, there is a scope for improvement. You can see on a single day, there was a hyperglycemic zone as well as a minimal hypoglycemic zone there. This is the shaded area is the target range, 80 to 120. And what does the normal look like? Look like this. Like this is a range, 80 to 140, where the pregnant mother has spent most of the time in that range only. And this is a pregnant mother, early pregnancy. Without knowing that she has got diabetes, she became pregnant and her glucose levels were on the higher side to start with. Once she was started on insulin, multiple doses, and the doses got titrated, and then you can see nicely she has controlled her diabetes to the target range. So this is the time in range. She's spending most of the time in range now. So this is the improvement in treatment. This is a everyday pattern trend. You can see each day plotted here. So from morning to night. So before treatment, a lot of times she was spending her levels at a higher range, which is harmful to the baby. Whereas once treatment got started, most of the times she was normal. And during pregnancy, if insulin is required, initial stages of pregnancy, since the insulin resistance is not much, the insulin requirement will be very minimal. Once you reach 22 weeks, then the insulin requirements start going up. That is because the placenta secretes more and more placental hormones, which increases the insulin resistance. Obviously, when you require insulin to control your sugars, as your own insulin action gets impaired, you will require more insulin externally. So it doesn't mean that you are failing. So you are doing well. It is the physiology of pregnancy diabetes. If you require insulin during pregnancy, most of the times as the pregnancy advances, you will require more insulin to keep your diabetes under control. And to reiterate the point that the injected insulin is not harmful to the baby, I've told you this before in this presentation also. If a woman is on insulin injections, it never crosses the placenta to reach the baby. Only the glucose reaches. So you must be more worried about the glucose rather than the injected insulin dose. Any number of units can be given. Sometimes in difficult patients, we have even crossed 200 units per day. It doesn't matter. The level of control and the safety of the mother is more important. And sonographic assessment is very important in pregnancy diabetes management because the sonologist at the appropriate times checks the growth of the baby. And they will be doing 4 fetal measurements. One is the head circumference, then the head diameter, which is called biparietal diameter, then abdominal circumference, as well as the femur length. Femur is the thigh bone length for the baby. So when they measure all this and plot these values into a formula and arrive at an estimated fetal weight, that gives us a fair idea whether this baby is growing too fast or is lagging behind. All that information can be derived from this report. And the abdominal circumference is one parameter which is closely going to tell us whether this baby is going to become big or reach an appropriate weight during the delivery time. So if the abdominal circumference falls between 50 to 75th percentile in the report, then your baby is growing at the appropriate level. And it's a common problem. What we face is when somebody gets diagnosed at around 12, 13 weeks of pregnancy, initially they are very much motivated. They follow all the rules. They regularly monitor and come for reviews regularly. Between 24 to 32 weeks, because something comes up, say, I'm going to my mom's place, or we are going on a holiday, something. So during that period, if the monitoring becomes lax, you are not very vigilant, then this can happen. So obviously the baby has started growing faster. If appropriate dose adjustments were not made with insulin therapy, then the baby can start growing faster. So this is a abdominal circumference measurement from a mother who just relaxed a bit around this time frame, and her baby shows signs of bigger growth. You can see the baby's abdominal circumference is touching the upper limit of the normal. So we need to be more vigilant around the time. And when it comes to delivery of the baby, if you have gestational diabetes or pre-existing diabetes, delivery may be advanced by a week or two. This you should be mentally prepared. You have a due date. The delivery may not go up to the due date. The gynecologist may choose to deliver the baby little early, because as we go close to the due date, the risk for the baby slowly increases. So after 37 weeks, any baby born after that time is a normal baby. It's not a premature delivery. And insulin therapy won't influence the mode of therapy. A lot of mothers do ask me, like, I'm on insulin. Will that be a reason for cesarean delivery? No, it is not a reason. If you have got good control with insulin, then still the gynecologist will give a fair trial of normal labor before deciding whether to take up for cesarean or not. And mode and timing of the delivery will be decided by your obstetrician, because the obstetrician is the primary consultant in pregnancy. So the decision of the timing of delivery and mode of delivery will be taken by them. But if somebody has got uncontrolled diabetes early on, and if the diabetologist feels that it's a high-risk pregnancy, they can always give their input to the gynecologist about the need to deliver the baby little early from the diabetes point of view. So delivery should be done in a center with a neonatology unit. This is very, very important. If you have pre-existing diabetes or you have gestational diabetes, it's better to have the delivery in a good center with a good support system. So once the baby is born, the baby has to be handled by a qualified neonatologist, and the neonatologist should be available all the time. So this is an important criteria for choosing the delivery center. And post-delivery, a lot of women do ask me, like, will breastfeeding the baby will cause diabetes to the baby? So if you have pre-existing diabetes, by feeding the baby, you are protecting the child. Actually, there is ample evidence that the breastfed infants, they have a reduced risk to develop obesity as well as diabetes in their later life than bottle-fed infants. So there is an early protein hypothesis which says high protein intake quite early in infancy stimulates insulin and IGF-1 receptors. The baby has got higher number of adipocytes as the baby grows. And high protein intake in infancy causes faster weight gain and higher BMI in the first 2 years of life. So if you can breastfeed the baby, you must breastfeed the baby. Don't go for formula feeds. And the pediatrician is the best person to discuss this once a delivery happens. And the next point is better pregnancy spacing. This is very, very important, because if you allow spacing between the first pregnancy and the next one, you are allowing the infant to have breastfeeding for a longer duration of time. That is very important. 2 year spacing, at least 2 year spacing, gives your baby 730 days of focused attention. So each year is 365 days. So if you leave at least 2 year gap, then it is 730 days of focused attention for the baby. And there is a better prospect of reaching back to your pre-pregnancy weight. So obviously, all of you would have gained weight physiologically during your pregnancy. So once the delivery happens, most mothers will lose a pregnancy gain weight and reach the pre-pregnancy weight at some point of time. But some of them tend to retain the weight. So if the next pregnancy occurs quite early, then you don't have any opportunity to lose that weight. So you have a better prospect of reaching back to your original weight if you delay the next pregnancy. And delaying the next pregnancy allows the time window for pre-conception counseling. You can always go to the doctor tell them about your previous history of gestation diabetes and go for the pre-pregnancy planning, which I have explained before, so that they can diagnose any abnormality in the glucose levels or any other medical problem and address that appropriately before allowing you to become pregnant. And obviously, pre-pregnancy spacing, before pregnancy spacing, improves your health and the fetus in the next pregnancy. This is an important slide. The kind of nutrition the first 1,000 days makes a difference for the rest of your life. That means the fetus is there for 270 days, 10 months, 270 days during pregnancy. And the first year is 365 days, second year is 365 days. If you add everything together, it is 1,000 days. So from the start of conception until the baby reaches or celebrates the second birthday, if the nutrition is good during these 1,000 days of your child, then the rest of the life, the child is going to have a very healthy life. This 1,000-day concept is very important, and we take care of the first 270 days, the gynecologist and the diabetologist, and the first 2 years of your baby's life will be taken care by your pediatrician. So before we conclude, I always feel the pregnant mother is doing a lot of things. Like she once gets diagnosed, she copes up with a new diagnosis. It is not a pleasant news to hear that you've got pregnancy diabetes or you've got pre-existing diabetes. And then she starts monitoring, follows a lot of rules as far as the meal plan is concerned. And then if the doctor advises insulin, then she takes multiple doses of insulin. Then, so she is doing a lot of things to keep the baby safe. Obviously, the mother's love for the unborn baby, that is our strength. Because this picture tells you clearly, God cannot reach everywhere. So he created mothers on earth. You can see that mom who is taking the child from the school has given the umbrella to the child. She is getting wet in the rains, but whatever that comes in her way, she protects her child. So you can see such motherly love even in the animal kingdom. On the right side, you can see the birds, the mom giving feed to the newborn. So this happens even in the animal world. So moms are the best persons on earth. With that, I conclude this presentation. If there are any doubts in the chat box, I'll answer now. Okay. There is a question. Is there a chance for the baby to be diabetic if the mother has GDM? Okay, actually, it's a nice question. Is a doubt which lingers in most of the mothers. Like, will my child become a diabetic? Obviously, this is not the case always. So we are treating pregnancy diabetes to prevent many complications and possible adverse consequences of for the baby as well as for the mother. It is not about the child becoming a diabetic at birth, but there are very rare cases where there is a condition called neonatal diabetes, so which can occur in neonates, but that is not closely linked to the mom having gestational diabetes. But having said that, if the mom has got pregnancy diabetes and she has not controlled it properly, then there is an increased risk for the child to develop diabetes in the later life. It is not about the child getting diabetes as soon as the birth happens. It's not the case. And if you have any doubts, you can still type your queries. I'll wait for a minute. I think anyway, if you have doubts, you can always type it. Maybe when I'm free, I'll definitely give my feedback. Thank you, everyone, for patient listening. At the end of this session, what I want to tell you is, if you get diagnosed with pregnancy diabetes, don't worry. You can cope up with that. So help is available. So just get motivated to keep your baby safe and take help from the professionals and follow whatever they advise. Thank you.